Thank you very much for coming back quickly during lunch. So we're ready to start the phase when we are going to do the voting, the further deliberation, and then the voting on clinical effectiveness and value. So I think just procedurally, why don't we go ahead and get you guys logged into the voting process again, and we'll do a test vote, and then we'll pause again to look at the questions and start to think about the evidence. So here is why don't I let Matt walk you guys through the test question here.
All right. So once you've logged in, everybody should either see an image of this slide on their phone or on their laptop, or if you're using the clicker, you won't see anything. So you'll be able to choose one of 4 responses, and you can change your answer up until the point where we close polling.
I don't know either.
Random guess.
So I didn't get any handout related to studying for these particular questions.
Yes, this is blind knowledge, and there is a trick. There's a trick option there, so I'll give you a little bit of a hint.
A trick option.
There's Gozerian.
Gozerian is.
Yeah, I don't think so either.
Oh, there it is.
I do like Gozerian.
Somebody's already figured out which one the trick option is. All right, so we're going to be looking for a total of 14 responses.
Do we need to enter or just, do we just click it or something else?
So you won't need to hit enter or anything. As long as your answer is highlighted on your screen, it should be fine.
Oh, okay.
Go where the Gozerian.
Sounds like we've got a few people who identified the trick option. All right, we're waiting for 2 more votes. Has anybody not voted yet?
Because that's the kind of crap that sticks in my head. I can't remember anything.
She's Googling.
That's definitely cheating.
How do you know your vote registered?
If you're on your screen, one of the options will be highlighted.
I think that's it. Okay.
Yeah, because it doesn't.
There's no enter.
Yep, there's no enter option. All right, well, we've got 14 votes.
Thank you.
All right, so we have a few people who fell for my ruse. So the correct answer is C, Celtic. It's actually derived from an ancient Celtic holiday called Samhain.
Good guess.
Roman and Sumerian were just kind of random options I put in, and those of you who are movie buffs will recognize Gozerian as the primary antagonist from the first Ghostbusters movie, Gozer the Gozerian. It's a little Halloween cheer.
You're very proud of yourself.
Probably a little bit too proud. That's where I get to shine. All right, so with that, I'll turn things over to Steve.
Clearly, we're going to have to take public comment on these test questions before the meeting.
All right.
So, obviously, we have a large body of evidence split in a way into these different interventions, and we're going to vote on each intervention. But some of the issues around the evidence may pertain equally, if you will, to all of them. So we may end up having more discussions sometimes on some of the first ones, and then the latter ones we'll kind of need to have less. So just to frame you again, your evidence summaries are in your blue folders. These are some of the key tables and material that you'll probably find helpful to refer to. And I've brought Jeff and Rick up to the front table along with the clinical experts and the patient representatives. So again, you can ask questions of each other, of them. And I actually have a couple questions before we even launch into this first vote. But let me just read it. For individuals with chronic low back pain, we're going to have all the votes on low back pain first. Is the evidence adequate to demonstrate that acupuncture provides additional net health benefit when added to usual care? So I'm going to take whatever prerogative it is that I have, I guess it's that I'm standing at the mic right now, to ask Jeff a couple of questions. Because as you guys recognize, these interventions are not pills, right? So some of the questions that we usually have about internal validity and external validity of the evidence are different. They're more like surgical procedures where we ask things about the expertise of the practitioners, about the variety of different approaches, and so I want to kind of get into that a little bit. But Jeff, let me just have you summarize again what you think is the key evidence upon which you based, and we based, I guess, the presumptive label of C+. And I'd like you to address as part of you, while you do that, why you decided, why the report says C+ instead of B+. if the majority of the evidence suggests an incremental net health benefit and there are no harms, why did you feel that the most appropriate rating of the clinical effectiveness was C+ and not B+?
I think in part
Can you try to just make sure the mic is captured?
Yeah, I should address it to everyone, not just to Steve. But I think two issues. One, I think I was partly concerned about the lack of differentiation from sham therapy. I mean, if we were talking about a surgical procedure and we were voting and we saw no difference between, cleaning out the cartilage in somebody with rough cartilage and osteoarthritis and just poking the holes in the knee and not doing anything arthroscopically, we probably would say it's an ineffective procedure. And so I think that played into my thinking here. It also, the net health benefits, in many of the trials, they were not significant reductions in pain. Put together in the meta-analysis, there were significant reductions, but the absolute benefits on the pain scales are small. By the time you get out to a year, it's about 1 point or less on a 10-point visual analog scale. So small benefits, but really the totality of the evidence suggests, especially when you compare to usual care, that there are real but small benefits. But I thought there was enough uncertainty that I didn't think because of the variety of trial results and so on, that I thought there was enough uncertainty that I didn't feel like it was unequivocally better.
All right. Now, when you say small benefits, are you suggesting that the average patient had a small benefit in their clinical outcome, or that the number of patients having a substantial improvement was relatively similar between the two arms, a little bit more?
So I was talking about the average benefit in the group receiving acupuncture compared to usual care. So in the slide, I presented the proportion of patients who had significant benefit, because that's probably clinically what really matters. There are clearly going to be patients who don't respond, but there are some patients who are going to respond quite a bit, and the proportion of patients who responded quite a bit. In the BEST trial, the Churkin trial was substantially higher, about 20% higher, so 60% versus 40%. That's I think a clinically meaningful difference in people who had a clinically meaningful response.
Okay. And so I'm going to keep going just a couple more, and then we'll open it up to everybody, because I want this may not factor into your votes that much, but I want it to be kind of noted as part of our report, because I know that policymakers will want to think about this. One is provider expertise. If we're taking a vote on the evidence on acupuncture, do you have a sense of whether the doctors or the practitioners in these studies are representative of the practitioners out there in the community who would be providing these services if this were a covered benefit, let's say? What would you say to characterize the types and breadth and experience of the providers in these studies?
I think it was quite variable in the studies. Again, in the Churkin trial, which I emphasized quite a bit, they all were licensed acupuncturists. I think the minimum time in practice was 4 years, up to 9 or 10 years. So they were experienced practitioners in the Churkin trial. In some of the other trials, as our speaker who represents acupuncturists here in this country, highlighted in some of the trials there was much less training for people giving the acupuncture. So it varies across the trials. But in the highest quality trial, it was providers who had extensive training and experience in acupuncture.
Okay. And I'm sure we will come back to this in the policy roundtable. And in that same vein, the variation in the treatment protocols, we've heard about from the public commenter that there's a huge range of approaches and durations of acupuncture. What was studied? The evidence that we're voting on, are we voting on, what brand of acupuncture are we voting on? Or again, was there a huge variation in these studies?
I may allow some of the experts up here to comment a little bit more. I mean, there was a range in the studies. Nobody did the level of acupuncture that was described in China. So these were a very limited number of sessions, 8 to 16 sessions, so over 2 months generally, something like that overall. So this was not long-term, frequent acupuncture. It was relatively circumscribed.
Okay.
Circumscribed, excuse me.
Thank you. So I just want to get those issues out on the table, make sure that they're kind of part of the record, if you will, and we'll come back to them, but I wanted to have kind of the evidentiary base for it when we come back to it at the policy roundtable. Great. Open to questions, comments from the panel. Christine.
So my first comment has to do with the question of the sham versus the real, and I think is the technique of acupuncture, or is it the experience of going to get acupuncture that we're talking about? And so I'm not sure the experience. I think the sham includes the experience in addition to the actual technique. So I don't know that it makes it, to me it doesn't seem to make a difference, but if the whole package of I'm going to get acupuncture and I go see somebody and they talk to me and whatever seems to have a benefit. The second piece I want to say is that back pain is multifactorial. It's not like an E. coli UTI and we're doing a test of one antibiotic against another, and it's a discrete problem with a discrete solution or not. It may be that this works, 60% may be about as good as anything's going to get, because a certain number of people will have a back pain problem that's cause is actually amenable to acupuncture, and another set it may be amenable to something else. And I think that's some of the problem we get with the significance of results for processes that we don't understand in the first place. So.
Okay. Penny, you had a comment?
Yeah. First of all, I guess in these trials, these were just people with low back pain and no other issues. Is that true?
Yeah, I mean, so these were chronic, mostly non-specific low back pain. So patients who had, significant radicular disease were generally not part of. Some trials did look at radicular disease, but most of them did not. People who had clearly surgical therapy, who had autoimmune arthritis, who had cancer, things like that, they were excluded from these trials. Trauma with fracture and things like that, they were excluded.
And we don't know if they were on other medications or anything. The thing I'm getting to is the expectation of the treatment, and we're not sure what people's mindset was when they went to this, whether they were, I'm going to prove this wrong, I'm going to prove it. I mean, there's people with pain are so very complex, and unless we really take time to understand what's going on with them, we don't know what their expectation of treatment is and how they may actually respond to it. And I guess my biggest thing, and I'll say it now and I can expound more on, is that doing one treatment for pain is just not good enough. You need to combine all of these therapies together with appropriate medical intervention and putting that patient at the center, making them responsible. And I don't know, like on other, on the other things, are we teaching them the self-care of all of this when we go with them? I mean, it's much more complex than what I'm hearing here, and that sort of bothers me about. So.
Robert, did you have also something to ask about the first?
I just wanted to add some comments to your question. There is evidence, not derived in these placebo pain trials, that the placebo effect of acupuncture does go beyond the needle itself. And that, for example, there's a study by Kapchuk looking at irritable bowel syndrome, and they had an acupuncturist come in who was very sort of cold and businesslike and matter of fact, and then one who had a particularly warm and patient-centered approach. And actually, in both cases, there was a sham needle used, and the acupuncturist with the warmer approach actually had a more positive effect. So that's certainly the case. But in these acupuncture low back pain trials, the providers were sort of equally, appropriate and professional. I will say this concept of this issue of the average effect size versus percent responders is a key one. So we would hope that in a trial of Septra for E. coli UTI, as long as the patient takes them, and most of the patients do, there should be a uniform effect. But what's different here in the non-pharmacologic trials is that you have differences in adherence, difference in the disease condition, and these variables difference in the preference or expectation that patients have. So, as one would expect, this is going to impact the outcome. So, I do think in this situation, seeing that there is a greater percentage of responders in the treatment group versus the usual, to me is more helpful as a clinician as I evaluate a treatment rather than that mean effect size, because the mean effect size includes people who went to one visit and didn't go further because it's appropriate intention to treat analysis.
All right, thank you. We have a lot of interventions to go through, but I don't want to curtail this too much. Are there any other questions about the evidence on the comparative clinical effectiveness for acupuncture that you guys would like to ask? All right. Please go ahead and vote then. We've got 6 or 7. I'll actually note now that I know it seems very efficient to vote early, but I would actually encourage you to wait until the full discussion is done, because every once in a while people find that their choices are changed, and it's probably better to wait. But go ahead and vote. We should have 14.
So if you click the boxes over, that'll change it from percent to egg values.
Say that again.
So if you just click that button, once it highlights, it should switch it. If not, we might not be able to do it.
No. All right.
2 more votes.
Right, 2 more votes. One more vote. So close. I wonder if it's Rob's or is it
yeah, no, it says the license has been exceeded.
Okay.
So I can switch over. That's the app. I can close the session. It'll take about 30 seconds.
All right, well, we're going to add Paul's vote to this total. You ready?
That's interesting. Do you want to?
You ready to vote?
Yes.
Yeah. Okay. All right. So it should be 14 yes, 0 no. All right. So we sometimes will debrief if there is a division of opinion, and we'll try to learn from that distinction. It doesn't feel like we need to learn from that distinction on the case of acupuncture. So let's go forward to the same question for cognitive behavioral therapy, exact same question. Jeff, I can see from table 4.7 that the net health benefit level of certainty and ICER evidence rating are the same. Are there any distinctions in the type, level, strength, generalizability, etc. of the evidence that you think we should note before the panel takes its vote?
I mean, the only thing, the only difference was, both CBT and mindfulness-based stress reduction were the only interventions studied in a trial that went out 2 years, and they did have ongoing benefits at 2 years, and CBT did have improvements in a depression scale and quality of life scale that often wasn't reported in other trials, but in this trial it was, and there were benefits particularly to CBT there. I think those are the main differences. There are fewer trials of CBT, but larger and high quality, so the overall evidence is about the same.
And again, ARC looked for publication bias and did not find it. Is that correct?
That's correct.
Okay. And again, just for the record, as much as anything else, what flavor of cognitive behavioral therapy? There was a public comment about the fact that there may be specific subtypes focused on pain or disability. Do you know more about what was in the studies?
So, I mean, I know that in many of the trials, again, a relatively circumscribed number of sessions and length. In a large trial with the 2-year follow-up, there were, I think, 8 2-hour sessions. They were done. They were group sessions, and I think in pain CBT, the interventions are more commonly group sessions, and many people feel like there is added benefit to reducing the sense of isolation that many people with chronic pain have, and that there's added benefit actually just from being in a group. So that's part of the reason that's done as a group intervention. Certainly, as in any of these, the expertise, the sensitivity of the individual leading these sessions certainly could impact back things, but there are pretty, there are pretty good guidelines and standardized approaches to this. So there always, I think, will be variation by practitioner, but I think there's enough evidence that people can be trained to do good CBT for pain that improves outcomes.
Okay.
It looked like maybe some of our experts had something to add to that.
Oh, yes, please. Dr. Prasad.
I was just going to reiterate that for CBT for pain, there are standardized protocols that are oftentimes employed across different settings. It's usually 8-week series, and a lot of the curriculum that's taught is the same across different settings, and it's usually very highly manualized, so there's pretty good consistency.
Right. So this isn't the old-fashioned couch and the doctor kind of free associating.
Not that.
CBT is very structured.
Yeah, and most of it is group-based for the reasons that were mentioned.
Right. Okay. Any questions from the panel about the evidence base for CBT? Christine?
Yeah. So CBT teaches you a particular way of thinking about the problem that you're having that's being addressed by that CBT set of sessions. How much does that spill over into how one thinks about other things in one's life? So if one is getting CBT for back pain, is that also going to spill over in how you think about your eating or smoking or other things?
Please.
So it absolutely will. There's carryover. So when you're learning some of the different CBT strategies for pain, of course, they'll apply to other things like depression, anxiety, things along those lines. And I think that's why, not surprisingly, we saw differences in depression scores as we look further out.
Great. Any other questions? No? Okay. Why don't we go ahead and vote then on this question? Adequate evidence to demonstrate that CBT provides additional net health benefit when added to usual care. Are we in the same ballpark? It worked? Oh, great. You're back online. Okay, here we go. All right. You guys are just completely confused about these questions. There's way too much dissension among you. All right. Thanks. Let's keep going. The next question is about mindfulness-based stress reduction. You know, one thing that wasn't in the oral presentation, and if you could just literally give like 20 seconds, what happens to the patient when they go to a series of sessions on mindfulness-based stress reduction? What is this? Whoever's best teed up to answer that question.
Go ahead.
Can you just describe it for the panel?
Sure. So very briefly, MBSR is a program that was established in the 1970s at UMass by John Kabat-Zinn, a psychologist. And what he essentially did is adapt certain Eastern meditation practices into a secular, manualized 8-week program that would be feasible to administer to a wide variety of Americans without religious background, et cetera, et cetera. So there are 3 main components. One is mindfulness meditation itself. 2 is some simple, gentle yoga. And then the third part is what's called a body scan. Mindfulness meditation is distinguished from other forms of meditation in that it is a moment-to-moment awareness of what one is feeling or thinking without any judgment. And so that's actually the critical piece there. And that's in contrast to some other forms of meditation. For example, a mantra meditation is where you concentrate on one thing, like a word. The body scan is very much like progressive muscle relaxation. You lie down and essentially a tape or the person guides you through different body parts, being aware of how your leg feels. Is it tight? Is it tense? Is it relaxed? So forth and so on. And that's been shown to decrease muscle tension, improve pain, etc.
Okay. And again, would you be able to comment, Penny? I'll come to you in one sec. In terms of the studies done, we read in the report that this has a very standardized training approach for the practitioner, so I assume that what we have in the evidence base can be assumed to have been fairly standardized MBSR across the board, right?
Yeah, I would say this is the most standardized of all of the interventions we're talking about today. Right. No question.
Okay, thank you. Penny?
What I wanted to say, and just to follow up on what you said, is it really, it's a learned skill, I think, for so many people. That's why I like to see the 2 years out, and I'd like to see more. And it really is teaching people to listen to their body first, to know when to begin to do those exercises, whichever one they choose to do. But it is very powerful, and we have found a lot of our people just in peer-led groups that use the relaxation stuff that we have, that have found it extremely useful. But it is a learned skill, and it takes practice. Again, it puts that patient back into that role of being part of the treatment team and being responsible. And that's key to all of this.
All right. Robert, did you have something else you meant? Okay. Any questions from the panel? All right. Please go ahead and vote. That was fast. Good for you guys. All right. Let me just take a wild guess. There we go. All right. Goes of the Gozerian wins again. On to the next one. Yoga. Same question, chronic low back pain. Jeff, I'd offer you again the opportunity to identify any specific distinctions that you feel are worth noting in the evidence base, either around internal validity or generalizability.
I think this is one of the areas where there are many yoga traditions and many yoga poses, and so I don't think there's great standardization across the trials. There's work moving in that direction, and I think there is better standardization, but I think that's a big issue here. I should say one of the reasons I gave C's to all of these is some of the uncertainty about the long-term outcomes. I neglected to say that when you asked that about acupuncture, but one of the concerns I have is, we have data out 1 year, but we're talking 5-10 years. These are lifetime. This is a lifetime, experience that patients will struggle with, and so it's the uncertainty around that also contributed to my feeling like it was only comparable or better, not clearly better. Though some would argue that short-term benefit is still worth it, even if long-term you're at a similar level. So I guess that's the only thing I would say with yoga is it's just a lot of heterogeneity in the types of poses. There was a question raised by one of the panel members, I think over lunch or at some point, about whether all patients could do this. And certainly there are some limitations to what patients can do based on their disabilities, but there's a lot of forms of yoga that can be done in a chair, that people don't need to be physically fit, strong, active to be able to participate in many of these programs. So I think there are programs that are really adapted for people suffering from significant pain and who start out with tremendous functional limitations, but they can still participate in this.
Okay. Questions from the panel? All right, please go ahead and vote. All right, there we go. If we were a baseball team, we'd be doing very well.
Even the Dodgers lost.
Question number 5. Okay, here for the first time we have at least a different preliminary evidence rating in the ICER report. So the same question for Tai Chi. Jeff, would you please characterize why you gave Tai Chi a different rating?
I think it's just a much less studied modality, and I guess one other thing I thought of after, with both yoga and Tai Chi, it's probably not, I don't know. I haven't teased out what exactly it is about these practices that impacts chronic pain, but both do involve some sense of mindfulness and breathing that may impact it. It may not just be the poses or the physical activity. There are other elements of these practices that may contribute, and partly why we thought of them as mindfulness kinds of or cognitive based therapies, not just a purely physical therapy. The reason for the lower evidence rating here was primarily smaller effect sizes in some of the trials and just smaller, shorter trials, fewer trials. It was just less convincing evidence here.
Can you or the clinical experts comment again a bit on the practitioners who were included in the studies and even the patients here? I just don't know if this came out of academic medical centers in major urban centers, or was this clustered on the West Coast where patients might have heard of or seen Tai Chi already? Anything you can tell us that distinguishes the practitioners and or the patients in these studies?
No, I don't think so. I think many of these trials are funded by NIH, National Center for Complementary Integrative Health, and I simply think the Tai Chi grants and research is sort of a few steps behind some of these other fields, but these are mostly coming out of academic health centers and similar, mild to moderately severe, severely impacted patients with chronic back pain.
Okay, thanks. Any questions? Alex?
And just to clarify, at this point, we're not supposed to consider the costs of treatment.
That's correct.
And if a majority of us vote that is not effective, we will have no opportunity to vote on the cost effectiveness.
That's correct. The cost effectiveness results obviously live in the report, but we won't take a vote on value.
Can I just ask,
Sure.
So wasn't the major study that you relied on, the participants were retired Chinese athletes? So that's what raised a question in my mind, is that generalizable?
Right. I wouldn't say I relied on that. I mean, that just was an additional study that sort of supported and was one of the larger trials. But yes, it was a very unique population. And I did try and highlight in the write-up concerns about the generalizability of that to a typical patient with chronic low back pain here in the United States. I think that was a very different population. Yeah. So again, it sort of highlights again the weakness of the overall evidence base here. There wasn't a 300-person trial of Tai Chi in the United States with a year or two of follow-up to turn to. That's one of the reasons why I highlighted the Churkin study rather than the German study of acupuncture, because I felt like it applied more to the U.S. Healthcare system and the kinds of patients who might be seeking that out here. So yes.
Rita.
I mean, just to comment on that, I think it's kind of a reflection of the funding for our studies, because there isn't a big industry around Tai Chi that would fund those studies. So, I mean, I understand, but it's a comment.
Right. And we should all remember that our votes are indicative of a moment in time, and it doesn't mean that the evidence is adequate to say that it doesn't work. It's just to clarify again, sometimes people are concerned that your vote is meant to imply that we do have evidence that it doesn't work or something like that. Ralph?
So my challenge related to this particular vote is that, if we're talking about TAVR and you're thinking and weighing in your mind, safety, efficacy, these sorts of things, the level of evidence in that situation, to me, has a very high bar. So when we're dealing with something that has no harm, and we won't discuss the cost issue at the present time, and in your comment, which I keep on internalizing, where usual care potentially could be more harmful than if you can avoid surgery and you can avoid opiates, which we don't have adequate data. How much is adequate evidence necessary with that type of bar? So I would be interested in some thoughts related to that in terms of evidence.
I feel like I should probably take a crack at that one for you, but it's a great question for you all to think about, because in a sense, it's very hard not to connect your vote to some action to be taken upon it. So to saying that there's not enough evidence mean that it shouldn't be covered by insurance, or that doctors shouldn't prescribe it, or that patients shouldn't pay for it out of pocket. So I know that's hard. But I would also say that even though there may not be any physical harm, you could consider that trying something that doesn't work at all is a waste of time when there are other known effective treatment options or with better evidence. So there's always some trade-off to be assumed, and so I would suggest that there is still a bar of adequacy of evidence, and it may not be the same as if when there are harms involved, but I think that there is a bar that's still certainly worth considering, because this is the first step that you would want to take for a patient or to guide a clinician or ultimately to guide an insurer about what to think about this intervention. So I didn't answer your question crisply, but I at least hopefully gave you some things to weigh as you make your decision. Paul?
Yeah, I mean, my somewhat answer would be, I have two bars. I have the bar where I'm going to recommend this to someone who wants to know what to do, and the other one is, will I prescribe it when they come asking for it? Which for me are two separate things. So, and I would have two levels of evidence in my own mind. Obviously, you have to reach the very top level. If I'm going to tell a person who maybe doesn't want to do anything, oh, you should really go have this. And I assume in the trials, all these people were interested in having acupuncture, but sort of by definition, I assume they signed a consent form and they knew. So they were all sort of interested in the first place in having that therapy.
Yeah. Christine, did you have?
There have been studies of Tai Chi done in other conditions, such as Parkinson's disease. How do these studies compare to those studies, if that was something anyone looked at? I mean, because part of this, is it possible to do a good study on Tai Chi? And if the answer is yes and these aren't, then, maybe that sways things a little.
Tai Chi has been studied more extensively for other conditions. I'm not as familiar with the Parkinson's literature, but I think that's actually still growing. But the area where it's really been substantial is prevention of falls in the elderly. And many large studies have been done, well done, and it's actually been incorporated into evidence-based guidelines. So I think it is possible to do rigorous studies of Tai Chi for health conditions. I don't see any reason why they could not be done in the future for back pain.
Okay. Excellent. Why don't we go ahead and vote? So, what do I click on? That one? Look at that. Very nice. 6 yes and 8 no. All right, why don't we can take a quote from the panel that will help people understand some of the different weights you put on that discussion that led you to a yes or a no vote. Would anybody be willing to describe their reasoning behind a yes vote? Bob?
I'm just going to go with the easy one, at least right off the bat. I would suggest the societal vision of yoga as a younger person's activity and Tai Chi as an older person's activity. And I think that's something that we can't disregard. If we vote that hard for yoga, I really don't see excluding Tai Chi at this particular point with this. There's certainly not a preponderance of evidence for it that we've got to go on, but there are indications that we can hear elsewhere. So because it's not here doesn't kill it for me.
All right. Anybody else who voted yes have something complementary, different to say that they like? Pat?
I was really conflicted. I was going back and forth. I think I wound up in the yes camp because I had a low bar. Mm-hmm. And I also kind of pulled out the sentence about the HRQ study saying that it did have an impact on pain, not so much functioning. So I kind of focused on that.
Okay, thank you. Anybody who voted no would like to offer what convinced them? Christine?
I almost voted yes on the thinking of, it's a low bar, the harms are small. I liked what Paul said about, would I acquiesce if somebody came to me saying they wanted it versus recommending it? I think that was a good dividing line. But then when I realized that, wait a minute, it can be studied and be demonstrated, so why hasn't it been done here? And so I voted no primarily because many times our no votes have been a driver to people to do studies.
Perfect answer. Okay, thank you very much. Anything else on the no side that people would want in the record? All right, that's very helpful.
I would say do a larger study.
Oh, please, go ahead, say.
Do a larger study.
Do a larger study.
Good start.
A larger good study.
All right, good. Thank you. We're doing well. Okay, so now let's ask a challenging question, as always. This is to see if you feel that there is adequate evidence to be able to distinguish the additional net health benefits that are provided by these different interventions. If you feel, how to deal with Tai Chi is challenging because some of you felt like there wasn't adequate evidence to say that it did provide an added benefit. If you voted no on that question, I think I would invite you to vote on this question as if you're only comparing the evidence on acupuncture, CBT, MBSR, and yoga.
Okay.
It would just make it more conceptually clean for you. If you want to include all 5 and the answer would be the same, fine. But if you're getting torn up about the Tai Chi issue and how you would lump that all together because you do feel like you could distinguish between Tai Chi and the others, then I would suggest you should take just the 4. Yeah.
Jeff, I wonder if you could comment on the level of evidence for differences in function of the primary outcome between these different modalities.
You put me on the spot. I would have to go back and look to really carefully say. I don't want to say off the top of my head without looking. I can try and look at the tables right now and point you to one of the tables. Certainly the evidence was variable, and some of them showed primarily reductions in pain and were more consistent evidence on pain and others on function.
That was my impression. My impression was that there was more evidence for reduction in pain across modalities, but for function, there seemed to be some that stood out more than others. For example, acupuncture in the trial that you showed us, 50% reduction in functional impairment compared to usual care.
And so, Alex, was your and Jeff, is the point that there just isn't that level of data on the others, or that there is, but they have very different impacts on or effects on disability?
My sense was they have different level of impact on function as measured by these scales. But
unfortunately, so one of the challenges is not all of the trials reported, substantial improvements in, they almost all reported the average reductions in these scales on as a continuous measure. The majority of the studies did not report the proportion of patients with significant reduction in pain or improvement in function, reduction in disability questionnaire. So many of the studies just didn't report that. It was harder to look at that, and so many of the assessments were based on the continuous measures rather than these categorical measures. There's, as Dr. Saper pointed out, there's been a movement in the research community to recommend that both get reported and that primacy be given to the proportion with a significant reduction. Unfortunately, there's also there are some standards that have been proposed for each of these scales about what represents a significant reduction, but there is still controversy about that, and it's not consistently reported. So it's a challenging area to really say something clearly about across the entire literature. And maybe our experts can add to that. I don't know.
I don't see any evidence for superiority of one of these over another in terms of function.
All right. Any other questions about your judgment of how adequate the evidence is to distinguish the net health benefits of this? All right. I'm going to go ahead and vote, please.
You can say that. Yeah. Thanks. It's just hard because it's fine. But I agree with you. I just didn't want to say that because if you like to spend a place to tell them how to answer the question.
All right. I'm sure that's, what is it, 12 and 2? Let me say. How quick? No, 11 and 3. All right. Might as well, again, for the record, at least the people who voted yes, would anybody like to tell us why you voted yes?
I voted yes because my recollection of the evidence review is that there were differences in function between the modalities.
We'll come back to that in the policy roundtable then. So you were looking at those differences in which, was it acupuncture that had the biggest impact on
That's my recollection.
Okay. So we'll come back to that then as it applies to questions about both clinical decision-making, referrals, for instance, and coverage. Okay. So let's go and start to vote on the value. So, and let me reflect now, because again, our approach now, our methods call for you to vote on value in full consideration of other benefits and contextual considerations if the kind of cost-effectiveness ratio is in that intermediate zone or gray zone or whatever you want to call it, between about $50,000 per QALY and $175,000 per QALY. So, in accordance with that, we would still vote on acupuncture and CBT and MBSR, but we would not vote on yoga or Tai Chi.
Yeah, sort of comparable because that's really usual.
So you can raise, if you want to, when we get to that specific item, there's going to be a question on all of them, but if any of you feel like there are strong reasons that you think that the base case cost-effectiveness ratio should be considerably different, in your mind than what we've presented, and here's that one-pager, which is the easiest place to find those.
Studies.
So for acupuncture, it's $53,000, just barely north of $50,000 per QALY. So, and as you remember, when we talk about other benefits and contextual considerations, they're on the last 2 pages of your kind of evidence summary. And I would actually just invite the patient representatives first, perhaps. Again, ICER's approach is to try to be cognizant of the fact that not everything is, measured in micro quanta inside clinical studies or in our cost-effectiveness models. So we have categories such as, would this intervention significantly reduce caregiver or broader family burden? Compared to other approaches. Will it have a significant impact on improving return to work or productivity? So I hope do they have a copy of this themselves? Great. So I'd invite you, do you have any thoughts on particular other benefits or contextual issues that, from the patient's perspective, you'd like to highlight for the panel?
What I would just say that...
Sorry, can you grab the microphone?
I'm sorry.
That's okay.
I didn't raise my sign. What I would say is, again, I didn't get an opportunity. I tried all of these early on, and I didn't get a chance to try them secondary a lot because I don't have that kind of money to do it. What I can say is I do water therapy. I was in that class for 4 years, and then now for maintenance I do water aerobics. And I can say that particular thing did improves my functioning and me being more limber. But I do know that CBT is good too, because it just, again, the American Chronic Pain Association, that's my discipline. I know that they give us a lot of tools to use, and those have been the most helpful to me in terms of CBT. And I'm also getting more into mindfulness movement.
Good. Well, let's come back in the policy roundtable and we'll talk about how those should be wrapped up as a package or done sequentially, or those are really important questions. We'll come back to that. Penny, did you have anything?
I think it depends on, it goes back to individual and what their needs are and what their treatment, what their expectations are for treatment. Well, acupuncture is a passive rather than active, because the more you talk about yoga and other things, it's a passive. For many people, I've heard it works, and for other people, it doesn't. And again, I think it depends on a number of different things that they're bringing to that treatment. I mean, people with pain are very complex, and it's been going on for a very long time. It's not something that just happened yesterday. So I really think you have to sort of step back and look at the person and the personality and all they've been through and all the family has been through. I mean, there's just, it's much more complex than looking at a single treatment. But what I guess I hate to see is to not have it available for people who will help. Because there's so many different treatments out there, and what might work for one may not work for another. But why would we not want to offer as many as we can, depending on need?
All right, again, hold that thought, because we're going to come right back to that as part of our policy roundtable. That's good. Does anybody have any questions or thoughts about their own view of the other benefits and contextual considerations that they feel are particularly important, relevant, or irrelevant in this area? Pat?
So a comment and a question. I guess my comment would be, I think you said no on additional benefits on your chart. I would say self-efficacy and mental health, which was in one of the studies, would probably apply to all of them because it does require some level of patient activation. So I would want that considered. And then Rick and I were talking at the break about administrative cost, which are not included in the model. And I'm curious from the panel, would the administrative cost of these programs be different? In other words, I would think something like acupuncture that requires oversight and credentialing might have higher administrative costs than giving patients discounts to go to their own teachers for yoga or tai chi or mindfulness training.
So you mean costs in actually providing it as an insurance benefit?
Cost, yeah. I think there's reasons why these programs aren't in place right now, and that should be a consideration, cost consideration.
Definitely.
Well, the first point I think everybody heard, which is that there may actually be health benefits that spill out beyond the measured ones that we focused on, pain and function.
Well, yeah, and one of them, was it the mindfulness study that had the SF-36 that included self-efficacy and mental health and showed improvement? I think the other studies didn't measure that, but I would assume since they are similarly cognitive studies that they would have that effect.
Yeah. And as for the second one, it's a good question. I don't know how to answer it. Again, maybe that might be the best thing for the policy roundtable, where we'll have the insurers up here and we can talk about what are the different administrative burdens and thoughts on how you would implement coverage for some of these areas. I think they're the ones who would have that expertise to have that part of the discussion.
Yeah, it just struck me this is different from an emerging drug where you've got an infrastructure in place through your PBM to administer it. These are programs that you would need to start up.
Yeah. Dr. Prasad, you wanted to say something on that?
I was going to say, related to the first comment that you made about the self-efficacy, I think that a lot of these active treatment modalities, such as yoga, tai chi, CBT, they certainly do help improve self-efficacy, just because the very definition of these are they're self-management programs. And so we also have to look at how that's improving. So pain is a subjective experience, and so we also have to look at how we're improving subjective quality of life, not just the qualities that we're able to measure quantitatively. And regarding the second piece, there are different barriers to implementing some of these things, but I think the policy roundtable might be a place where there'd be more discussion about some of those barriers.
Good. Okay, Joy, and then Rena.
I would just say that even though there is obviously some administrative issue for all of these, in some ways acupuncture sort of fits the medical model better. And so for that reason, I think in some ways easier to incorporate. For example, at our health system, we have an acupuncture practitioner, and I can refer to that person very easily, whereas these other modalities are much more complicated for me to find the right place to send the patient to. Now, that doesn't mean the patient's insurance covers that acupuncturist. That's a whole other issue. But it's just like administrative burden is not so straightforward as you might think, I guess.
I just want to make sure, first, the semantics of the question, long-term value, long-term, but the trials are...
The longest term value we've given you is 5 years. So that would be the framework within which we'd want you to consider this question.
Though most of the trials are much shorter than 5 years, right?
Well, in other questions, we will ask you long-term value for the lifetime, and they'll still be very short-term. So here, though, in some ways, we've actually made it closer to the amount of data we actually have.
Steve.
Yes, Rick.
The other thing I'd point out around that is that if you recall the scenario analysis with shorter time horizons, once you got to about 3 years, it really seemed to level off. So longer term, it would probably go down more, but not substantially, I would expect.
Okay. Yes, please. Yes.
Okay. I just wanted to say that I think when we look at the long term with anything that's alternative, and I'm glad to see this happening with different modalities as opposed to this is a pill and go take it. So I'm a person that advocates for myself a lot. But acupuncture and the discipline of medicine that the group I belong to, they do offer it. The only thing is they don't offer enough sessions. One session per month, duh, I'm sorry. That's not going to get it. They need to have you come more frequently for a longer period of time. So I'm glad that they offer it. And I've told my doctor that, but they need to increase the frequency. So I'm just glad to see that these alternative disciplines are being offered on any level, especially for people that are just newly injured. I think this is really important for people to be able to use, and even in the long term, because as Penny said, you'll do different things at different times. Like I'm ready to do acupuncture again, and yoga. Tai Chi might be a little too rough for me, so I don't know when I would try that. So thank you. That's my comment.
Thank you very much. Robert.
I just wanted to validate your point in that in the acupuncture situation, the administrative costs of implementation are very similar to another practitioner in your clinic. So you need to credential them, privilege them, create a schedule template. The same front office staff checks them in. You need a room for them. Your billing staff sends a bill, and so it's very akin to an individual practitioner.
All right. Why don't we take a stab at this vote then? So in looking at the incremental cost effectiveness, your judgment of the comparative clinical effectiveness, these other benefits and contextual considerations, is the long-term value for money low, intermediate, or high? Okay. Got low 7%, 79% intermediate, and 14% high. All right. Click. Oh, yeah, sorry.
Excuse me.
111.2. All right, so we had a preponderance at intermediate. I feel compelled to ask a little bit quickly, hopefully, about each. So low value, I just want to see if, because you all voted that the evidence was adequate to say that it was better than usual care, cost effectiveness just above 50,000. Who voted low value on that one? Could it have been a mistake of your voting? That's why I'm asking. If it is, that's okay. We can change it in real time. So just somebody voted low.
It was me.
All right.
Ouchie.
Did you intend to vote low?
I wanted to go low. I felt that I felt that it clearly had benefit, but that because it's not just acupuncture, but some of the sham issues, and I felt that it was more complicated than just sending somebody to an acupuncturist, and that in and of itself was actually what's giving them the benefit. And I felt that with the different studies and the fact that that there was a benefit, even if it wasn't necessarily a trained acupuncturist, we had more to learn from additional studies.
Okay, thanks. Most of you voted intermediate, so it would be interesting to hear a distinction of why you chose intermediate instead of high or low, perhaps. So among the many of you who voted intermediate, do you have a thought on why it wasn't high, for instance, since this is one of the lower cost effectiveness ratios, certainly in your reports that you will have seen? So anybody willing to say, here's why I said intermediate? Bill.
I voted intermediate because I saw other benefits that didn't have to do with pain elimination or reduction, but had to do with tolerance, had to do with coping skills, and had to do with patient engagement and activity, which were benefits that that enabled the patient to live better with the condition, and that has to be factored into a value issue.
Okay. Any other perspectives on the intermediate vote? Jeff?
Well, I mean, trying to be consistent with our structures, it certainly is well within the range of the 50 to 175,000 that we voted in for different drugs before, and if we're going to try to be consistent, we should probably be consistent. Much as I still am kind of cheap, and 50,000 seems like a nice number, it is in that range, and I think that that's where you would, kind of have to fall in the intermediate range. And again, as people have pointed out, doesn't have a lot of downside side effects to it either, so contextually it's got some benefits that way in terms of just applicability.
Okay. There might be other perspectives, but let me just, for sake of the time, someone who voted high value want to indicate their reasoning? There were two of you. Alex?
I voted high value because I thought it's close enough to 50,000. I'm going to check the less than 50,000 box, and in a lot of scenarios when they varied, when you ran simulation studies, is less than 50,000. And the main thing that drove my rating was a contextual consideration. Though we lack evidence, if it's relatively inexpensive, few harms, likely effective at reducing pain and disability, and it may reduce the opioid epidemic, I'm going to give it the benefit of the doubt and go with high value for now.
Thank you for bringing back in an issue that we hadn't, that we introduced at the beginning, but actually hadn't come up in a while in the discussion, so that's helpful. All right, thank you. Why don't we go ahead to the next one? Let's see. The next one is CBT. So now the kind of the base case, if you will, cost effectiveness has shifted to $93,799 per QALY. All right, we have the same broad perspectives. We want to have the same broad perspectives on other benefits and contextual considerations. So let me just ask the clinical experts, perhaps, is there anything about the other benefits of CBT that you would highlight that should come into a consideration of value, especially when you're thinking of it kind of in contrast to the other kind of interventions that we're talking about today?
So one of the things with CBT is, I would say, it echoes back to one of the previous comments made that while we do CBT for pain, it also has carryover effects in other areas. And so if we really want to look at the true comparative effectiveness and cost effectiveness, we'd also have to look at the other things that it impacts, such as depression, which was one of the things that was studied, anxiety, other things. But again, since depression is one of the things that was noted in the study, there's also a cost associated with depression that's not included in some of these equations that we have. So it tends to have very generalizable effects across a broad range of disorders.
Okay, good. Any questions or comments on that or other issues from the panel? Yes, Robert.
I like the sustained benefit 1 and 2 years.
Okay. Any other thoughts? This is your opportunity to convince everybody else on the panel that your vote on value is right. So if you want to jump out ahead and do that. Okay, why don't we go ahead and vote then? All right. So I'm taking it that Kim, you moved to intermediate?
Yeah.
Everything's confidential here except for that.
Even though it's more expensive, I thought the contextual benefits of being able to cope with anxiety and depression, it was so it sold me on this as being really, really important.
All right. And a person in the high bucket fell into the intermediate bucket.
That's me.
And because the higher
cost was higher.
Cost per quality. Okay. All right. Thank you. Let's keep going. We have one more to vote on. That's MBSR, with the base case cost effectiveness of $65,691. People can feel free to quibble with that now if they wish, but also in thinking about other benefits and contextual considerations. Again, clinical experts, I think we've already talked about what this is, what it is from the patient's perspective. Anything else that jumps out distinctively as an other benefit or contextual issue around this that hasn't been discussed already? No, I was just asking, looks like Robert has something.
A similar comment to what Ravi said about CBT is there's evidence for depression, anxiety, also just overall symptom reduction in patients with multiple comorbid conditions.
Okay. Looking forward to the policy roundtable. Lots of juicy issues to take on. Any other issues around the value question here? Please go ahead and vote then. I recognize that. All right. Okay. 0, 13, and 1. Excellent. Let's move on to just a couple more voting questions, and then we'll be able to take a short break before the policy roundtable. So the last two questions, or one question perhaps, is about neck pain. Oh, I'm sorry. No, we don't have to go through these, though.
Can't skip you.
Yep, we don't have to do those. Okay, so acupuncture for neck pain. So
yoga.
No, but yoga was, they were below 50,000 per quality.
Oh, so we're good on
So it gets a get out of jail free card. It's kind of, it may have other benefits too, but it's going to be considered high value.
High value in there.
It's a near studio.
For individuals with chronic neck pain, is the evidence adequate to demonstrate that acupuncture provides additional net health benefit when added to usual care? So take a deep breath. We've spent a lot of time thinking and talking about chronic low back pain. Jeff, I'm therefore going to reintroduce your opportunity to remind people what the evidence base is this for and why it was promising but inconclusive.
Right. So the effect size on pain and function were similar for acupuncture when used for chronic neck pain, but there were fewer studies, smaller studies, so greater uncertainty. One could argue, if you wanted, that using a pretest probability from the effectiveness in low back pain and carrying that over, maybe you would give it an extra bump up. So you could certainly argue that way as well, just to round out my thinking about this. But I thought there still was uncertainty, hence the promising but inconclusive here in my estimation.
Can I ask the clinical experts, in the evidence-free zone that is sometimes known as clinical practice, what do clinicians think about the level of evidence for acupuncture? What do they think? How do they feel through this issue of the different amounts of studies between neck pain and low back pain for acupuncture? Is it viewed as, I don't want to put any more words anywhere. So just what's your take on what the academic/clinical expert community thinks about this issue between low back and neck for acupuncture?
I'll take a stab at that, but it's worth making the distinction between academic communities and sort of clinical, communities. I think in the academic community, there's certainly less evidence, less compelling evidence for neck pain. However, I think if for individuals who sort of routinely recommend acupuncture for chronic low back pain, they absolutely will recommend for chronic neck pain, despite this difference in evidence.
And do you think that that's because they know the evidence and they just feel like it's just immature and it will get there to show that it's as effective in neck pain as for low back pain? Or, is there a logical kind of thread to the way that they're thinking about this?
Well, in the non-academic community, I think many of us are aware that decisions are based less upon evidence or aware of the evidence than their own clinical impression and patient preference. So I wouldn't say it's necessarily based upon the evidence. I would say, though, that chronic neck pain is, in my clinical experience in working with these therapies, it is a more challenging condition to successfully treat, I think, across the board than chronic low back pain. So that's just 2 cents, but that's personally what makes me think that we do need more studies on that.
Okay. Dr. Prasad, would you?
Just going to say, even with the more limited evidence for neck pain, one of the things that guides a lot of our principles is the cost-benefit analysis in terms of risk and harm. And if there's a potential for benefit and minimal risk of harm, we'll oftentimes make that recommendation for people if it can help improve.
Okay. All right, which raises the old question that Ralph raised for us. Different bars, different situations. I'm sorry, Joy, yes.
I just sort of have a follow-up point to that, and it honestly doesn't change my opinion about the quality of the evidence, but I think neck pain, the options are perhaps even more limited than back pain for treatment, and the surgical alternative is even more terrifying for neck pain. I mean, the potential harms of surgery for neck pain are awful. So in that context, I can imagine myself, despite the lack of evidence, referring somebody to try acupuncture, certainly before surgery.
All right. Any other questions or comments, Rita?
I would just echo that when it says adequate, my bar for adequate is a lot lower for this because of all the reasons that have, little harm, and the alternative seems to have a lot more harm. So you can see by the audience that there's not a lot of money on this.
A lot of patience, but not as much corporate interest. All right. Other questions or comments? I'm glad we decided to have this vote. Yes, Catherine.
I just wanted to make a comment. In facilitating a support group, I have quite a few clients. I shouldn't say clients because I'm not working, but I have a lot of people in my group that do have neck pain, and they feel that they don't get alternative suggestions for their neck pain. And for a time when I first injured my back, because I was so torn that I did have neck issues. I had to, learn how to turn again. When I would go to the gym, the ladies would say, even for my low back pain, Catherine's here because she's talking to herself, because I had to learn how to move everything differently for a long time. So I just need to advocate on behalf of them that, again, trying something different is better than nothing. And I don't know the stats on acupuncture for that. I read it, but I think they deserve a right to have acupuncture as an option.
All right. Thank you for that comment. All right, why don't we go ahead and vote on this question on the clinical effectiveness? To do it. There we go, 11 and 3. All right. I think, honestly, we've heard the issues about the levels of evidence and the different reasons that people might feel that it's a yes instead of a no. So we'll go with 11 yes and 3 no, and that means that we have one more question on the value. Oh, that's right, we didn't model. The reason that there won't be a value question on this neck pain is because the evidence was, in a sense, so much less substantial to be able to compare it to usual care that we did not create a model for neck pain. So that doesn't mean that the issues and the cost of acupuncture for the neck pain will be part of the review. Okay, so that's fantastic. We are 2 minutes ahead of schedule. Great work, everybody. So why don't we just take a 15-minute break? That will allow us just to kind of stretch our bodies and not develop chronic neck or back pain, right? And we will reconvene for the highly anticipated policy roundtable at 3 o'clock sharp. Thanks.